We collect probably hundreds of millions of hemoglobins from patients. Why are we not using something that's much more complex?
Dr. Travis Zack is Chief Medical Officer of OpenEvidence, the fastest growing application for physicians in history.
If we're saving any time on operational tasks, we need to at least reserve some of that back for what medicine is supposed to be about. Otherwise, we'll actually deliver worse care to more people.
We explore his journey from studying the biomechanics of mantis shrimp as an undergrad at UC Berkeley to becoming an oncologist, an AI researcher at UC San Francisco, whose work uses artificial intelligence to unlock clinical insights hidden in the medical record.
I want to make sure everyone's getting standard of care. And then I want to make sure that every physician has the tools they need to really feel like that's where the human really comes in.
In this conversation, we discuss how AI is reshaping how doctors access and apply medical knowledge and how the future of medicine as we know it will change.
Welcome to Stanford Department of Medicine's Inside Look at the Future of Medicine.
Travis, thank you for being with us today. Tell me more about yourself. I had a lot of fun learning about you, and one of the things that you'll know is I learned that you started off with a dual major at UC Berkeley studying the mantis shrimp.
Yeah.
But before you answer the question, so you brought the shrimp from Hawaii, where you're from?
Yeah.
So were you booking them on a bag and checking them on a plane from JetBlue, or?
So that is a long time ago. I actually did not start in science. I thought I was going to be a philosophy major. I took a physics class as a breadth requirement. It was the hardest class I'd ever taken. I took physics for science and engineers. It was very difficult. And I decided, well, I actually really enjoy doing very difficult things. It's a sense of accomplishment. So I'm like, this is the hardest thing I've ever done. I'm going to be a physics major. Ended up, I've always been a naturalist into conservation, so I took a lot of organismal biology classes for the field trips and ended up double majoring. I did research in imaging lab while I was there at Berkeley, and then also got into research in organismal biology for biomechanics. So that's how I ended up working in mantis shrimp. I did have a spring break project where I was in Hawaii. I'd done a lot of diving in Hawaii, so I was a pretty good swimmer. So my spring break, we went specimen collecting, not in Hawaii, but in Catalina. So I was paid to go free diving for shrimp and lobsters and stuff. So that was fun. So had fun undergraduate career. Was not doing anything medicine related. I actually, I didn't come from a family of physicians or scientists, really, and didn't actually recognize that there were doctors that did medicine. I know that sounds silly coming from here, but if you're on a small island growing up, it's not something you think your doctor is the one that fixes your knee, not necessarily does research. So when I was exposed to that during graduate school, I actually did a turn both from a research perspective, then went back to medical school. Used a lot of the quantitative skills I learned during physics to answer questions in those fields.
So you did the dual major undergrad,
Yep.
then you do biophysics PhD, but you're
Yep.
doing computational genetics.
Biophysics typically is like a couple different things. Imaging is one big part of it, and then the crystallography, and then there are neuroscience components as well. I was very much in the imaging route. Like I thought I was going to do imaging, and the first couple rotations I did were in that realm, doing imaging. Towards the end of my last rotation, my mom got breast cancer. And I was going through this phase where I was like, I felt like any papers that were derived from this would be very esoteric, very small, wouldn't answer the big questions I was really excited about. So I had a kind of change of heart where I was like, I want to do something involving cancer research. So I asked to join a lab. I actually just got to meet him again, but did a rotation in a cancer research lab, very much cell culture stuff. I had never touched a pipette. I didn't know anything of what I was doing, probably contaminated all sorts of things, but they were very nice, and it was my first exposure. And I decided I really wanted to solve this problem. And the problem I was very interested in is, why does cancer happen? And it was a very good place to be, because at that time in the 2010s to 2020, the Broad and the Harvard and the Broad were doing a lot of sequencing with large data sets where there was a lot of noise because there are all these passenger events that occur in cancer. And I got to work with a bunch of people working on designing algorithms to identify what's causing cancer, like what are the driver events in cancer. Got into that, and then it's a slippery slope, and I went and applied back to medical school.
Even at that early point, you're working with a lot of data, and computationally.
Yeah, exactly.
This is a technical question, but at some point, that's not really in the AI realm yet, right? The
No,
AI comes
correct.
it more in medical school? Like, how did you
Yeah.
transition into the direction you are now?
For most of those genomic projects back then, it was mostly statistics, like fancy statistics, so biostatistics, and how do we create p-values more or less from large data sets, and that's most of what I did. In medical school, I started to get interested in machine learning because of exposure to what clinicians, the data clinicians were seeing. I was kind of a third-year student, and we were on rounds, and the moment for me where I felt like we had to do something different was we were arguing over in rounds about whether a 0.5 drop in hemoglobin on an inpatient was relevant. And I just felt like we've only had 2 data points here. And we're using none of the information that we really need to determine if this is relevant or not, right? Like, we collect probably hundreds of millions of hemoglobins from patients throughout the entire, hospital history. Why are we not using something that's much more complex to help guide that decision making? And that led into the realm of machine learning, right? How do you take data points from disparate sets and try and just come up with the right answer, right? Like the what direction is this going, a prediction. I got interested and taught myself a lot of the machine learning models. Again, great place to be. I will say at that time, in the HMS system, it wasn't very easy to get your hands on real world data. It was very hard to do as a researcher, despite being in the genomics realm. What I was very interested in is how do we use the outcomes in the real world and the genomics and pair those to create predictive models, and it was very hard to do that in MGH and Brigham. Stanford and UCSF were doing a very good job of that with the Tool Butte and NIGM, the guys that were really visionaries in that realm, right? So I sent an email when I was applying to residency to a tool, and it's like, I'm really excited about what you guys are doing, and came out here both for the training but also for the ability to work on these really large data sets to develop machine learning models.
You come here, you do your residency and your fellowship in oncology. Now you have a research lab, and of course now you're the chief medical officer for a very important company, OpenEvidence, that all of us are using. I love AI. I use it nonstop. But I was one of the first people to sign up for OpenEvidence.
Oh, really?
But then I hadn't been using it until more recently preparing for this. And then I got back into it over the last couple of weeks. It is amazing.
Yeah.
It is absolutely amazing. And I promise you, moving forward, it is going to be one thing I use every single day. The ability to ask questions, and I want to chat with you more about these, the deep consult. I did different questions and compared side and side, and there's a lot going on there.
Yeah.
And the most wonderful thing that I want to hear from you today is, where are we? Where do you think we're going with all this? What's the future of medicine in relation to all this? Congratulations. I mean, you have 100 million, just last year, Americans alone being treated from consult from...
I often think as a clinician, right, like a lot of burnout comes from not the paperwork, which is true, like we have a lot of paperwork, but a lot of it is like the angst about the right decision making, right? Like, did you make the right decision making at the end of the day? Like, what are the things you could have done, you didn't do, those kind of things. And that's exhausting. I think it's one of the privileges, but also the onus of being a physician. And now I go to bed thinking about, there's 950,000 questions being asked by doctors every day that's affecting patient care. And did we do everything we could today to make sure every single one of those was as good as we can make it? Still a lot of angst. So it's very exciting, but it's also it feels like a lot of pressure to make sure we continue to be as good as we can be. I'll just push back on one thing, right? So I am the chief medical officer. I am very lucky. I kind of just fell into this, right place, right time. So I was doing machine learning stuff. I was doing it in fellowship for real world data. I had this separate project for medical education, where pre-GPT, I was interested in how do we find the right case. So when I'm a resident and teaching, I can teach based on a case that's related to a patient we're seeing, right? It was a project using old NLP tools, total side project, just out of passion. I got connected to the group at MIT building what eventually became OpenEvidence because of this, right? Because I was doing this medical education project. And there weren't very many clinicians doing NLP at that time. Zack and Daniel Nadler were the co-founders of this, and I've definitely basically fell into, luckily, all this excitement and stuff. And obviously it was very excited and feel so privileged to be able to help build it. But it's definitely, I want to give credit where it's due.
You're at the right place, the right time, but you're also the right person.
Yeah. I did see the The natural language processing in 2018, 2019, 2020 was super frustrating in real world data, right? But you could see that things were starting to change and there was potential there if you were like in the field. So it was exciting that I was like, yeah, I was in the field at the right time.
You gave this talk just earlier this year. There's multiple aha moments that I'm still getting from OpenEvidence, that the amount of power and different data and how you can do all that data.
Yeah.
I'm a generalist. You talked about how even you were a generalist before you became an oncologist.
Yeah.
You thought that there's an algorithm. Patient gets the algorithm,
right,
and they go through the algorithm. It's done. But life is life, right?
Yeah.
They get symptoms. They have issues. No one actually gets what the studies tell you you're supposed to get.
Yeah, exactly right.
Tell me more about how OpenEvidence, how AI can address that.
How it can address it now is helping physicians identify where other people have tried to find that, find a solution to that. And that can be piecing together breadcrumbs within the evidence. More and more, I'm hoping that that can actually, once we, we identify that this is the closest thing, how to extrapolate from that. To your point, what it can do is say, here's, for example, in oncology, here's how far the evidence can take you, and here's what's missing from that, based on where you're at. Like here's where you're gonna have to make a decision. I'm really excited for the future, which is now that we have such a strong understanding from an AI system level on where the limitations are. How do we push the people who have the power to actually fill those gaps? And whether that's fill those gaps can mean many different things. The simple one is we'll run the trial, or like we found what could be potentially a new drug interaction based on how often people are asking questions about this side effect. We should actually go study this in a prospective way. There's another gap, which is things that will never get a clinical trial. How do we find the right expert to answer that question? Maybe it's not evidence-based, but it's in such a way that it's better than what we have now, which is nothing. And how to do that responsibly so it's very clear that this is an expert opinion or consensus as opposed to an evidence-backed decision. But it's still better for a community oncologist to have that versus nothing. Because we have such a great landscape of where questions show up and where questions show up where the evidence is lacking, we can be very targeted about trying to fill those gaps, and we're working on that this year. Like, how do we identify where those gaps are and then go find the right people to fill them? I think those are the couple areas that we've been interested in.
Your research, direct research, is about taking the medical records where a potassium is 4, great.
Yeah.
Numbers are numbers, but you take the text and you provide meaning. Real proof data out of the text. Tell me more about that.
Sure, yeah. So I'll tell you a project I'm really excited working with a couple graduate students in Berkeley about, and it's around chemotherapy management. So despite all the things we've done regarding targeted therapy and immunotherapy in cancer over the last 20 years, most patients still get some form of traditional chemotherapy at some point during their cancer journey, at least metastatic patients. Those chemotherapies have a lot of toxicities associated with them, and poorly understood toxicities in terms of how to manage. And so oncologists, the art of medicine in oncology a lot is this balance between efficacy and toxicity, where both of those are unknowns when you make the decision. You don't know whether dropping the drug or decreasing the dose is going to affect the efficacy because a clinical trial wasn't run that way. Like if we gave 30% less of the drug, we don't know how that affects efficacy because the trial was run at 100%. Nobody did a 30% or a 70% arm. So we can't tell the patient that it won't be 100% efficacious, right? It's not a linear relationship. Similarly, toxicity, we don't know how much is the right amount to drop it such that a toxicity is avoided. And those are both short-term toxicities or catastrophic toxicities like hospitalizations, but also things like peripheral neuropathy that can last the lifetime and actually can be more debilitating than the cancer ever was, right, at the end. So what we're using is, rather than what we used to do for these predictive models was say, oh, this person had neuropathy, so we're going to try and train on neuropathy and see, can we predict whether someone will get neuropathy or not? We now can look at what symptoms the patient was actually describing in a natural language way during each cycle of the chemotherapy and how that progressed, to try and train a model to say, when they're describing the chemotherapy going from their toes to their feet, if we drop the cycle then and we decrease the dose, we can avoid the toxicity that persists past 6 months, which is really debilitating. And so using a combination of the language the patient is describing to the physician along with the other features that are traditionally used, try and find a better predictive model to balance that efficacy and toxicity. Again, nothing open evidence related, but those are the kind of projects and things that I'm trying to work on in the lab.
Do you foresee, and this is kind of bouncing back and forth a little bit with open evidence and then just AI, maybe it'll evolve open evidence or not, but open evidence is developing relationships with health systems such that I'm guessing you just do your medical records and then the stuff comes to you you don't have to copy and paste to another and then look up questions. It's integrated.
Absolutely. Yep.
Do you think that not only will you get the great content you get from evidence-based, PubMed, sourced, and so on, data, but also it'll also take that data to the next level and say, your patient is starting to have increasing neuropathy, make these changes.
So I'll talk about a middle step first, which I'm also excited about that we're already doing, and then we'll talk about that kind of final step, which is proactive instead of reactive decision making. So the middle step is when a physician makes a decision, making sure that every single one of those decisions, they understand the evidence behind it. So not making decisions like proactively, but when a clinician's made a decision, just putting the evidence front and center on that process. And the way we've done that is with AI Scribe, and I know there are a lot of AI Scribes. We built the AI Scribe with a specific goal in mind, and that is that when you write your note and you have an assessment and plan with bullet points, every single one of those bullet points, we've asked OpenEvidence what it thinks about that decision based on the patient context. We're not going to countermand that decision, but what we are going to say is here's what we found the evidence to support that decision is. And we put it within the note in a little chip, so it's like the one sentence summary where you can click out and read the full OpenEvidence. This is the full research on that, where we've asked 20 questions for you, basically. When you sign the note, it all goes away. Nobody wants any of that in their documentation, but it's a way of bringing in the evidence and the reasons you're making the decision directly into the workflow to make sure that we know why we're doing what we're doing. And if something's changed, make sure that we bring it front and center so the physician doesn't have to ask the question, did this change?
So the AI Scribe, I'm the patient, you're the physician, we have a regular conversation, it scribes it, creates a note. But the extra thing you have is you have the power of open evidence, evidence-based, that comes in and tells you, based on the evidence, here's what we recommend. You decide, and then when you're done with that, it gives you your beautiful note.
Exactly. With one thing, I will say, we easily could provide the recommendations. We felt like that was a little paternalistic. So what we're trying to do is you write the note, you say, this is what I'm going to do into the box, or you write it out, and then to say, here's the evidence behind each of what you did, including if it's zinc for a cold or whatever it is, there's maybe not a lot of evidence for that decision making. That was a product decision we made, and we'll talk about the next step in AI. But for this one, the idea was we're not going to tell someone how to practice, but we're going to say, given you're practicing this way, here's what the evidence says supports that practice. Does that make sense?
Absolutely.
Yeah.
When you have these relationships, so you have to have a relationship to be able to be integrated in the electronic record, do you also have the opportunity to get the data so you can eventually get to that final step?
Yes, so we don't do that right now. Obviously, because of the responsibilities the health system has with their data. So we don't train on data that's patient health information that's coming from health systems. Even when we're working those systems, direct integration with a health system, data stored for a very limited period of time, just so we can write the note for it. Instead, what we're excited about is this next phase. And in the next phase, we have open evidence running within a health system, not externally, but within it, so that whenever there is a change in the evidence, or whenever there is a change in the patient note, or the patient chart, we can actually proactively surface that and identify what changes we might recommend based on a change in the literature or a change in the patient chart. And I think pairing those together in a way that is very sensitive and very specific. And that is the last piece, is the one that's very important, because there are a lot of things, if you look at any given documentation, any given patient, that are not evidence-based, but there are very good reasons for that, right? Like there's a conscious decision being made by the physician for why they are not doing something, and that is based on knowledge that may or may not be present in the medical record. And so we have to be careful not to create alarm fatigue based on recommendations. That is all research we're doing with health systems right now as opposed to an active product, but that's where, in the future, that's what I'm very excited about, because physicians don't have time to go through, like every single time something's changed in their medical chart, again, not inpatient, but even outpatient, right? And every single time something's changed in the medical literature that might relate to this patient to make that update, much less see that patient every time it happens, right? You know, it's like, why should we in 2026 wait 6 months to make a change to a patient just because that's when we happen to see them? Is there some way that we can be slightly more proactive about when changes happen to extend patient health? So that's a vision. It is not a reality, but that's what we're aiming at.
One of the beauties of OpenEvidence is the trust but verify, the fact that comparing other LLMs out there, the difference with OpenEvidence is the risk of hallucination goes down because you're dating back to source reference material that is, we all understand that we agree that is a source of truth.
Yeah.
Peer-reviewed journals from the best journals that exist. OpenEvidence has an option where it's deep consult, where I love that. You give information, then it comes and asks you more questions.
Yeah.
I have a history of atrial fibrillation in my 20s.
Yeah.
I'm running since I was a little kid. I don't take omega-3s because I've read that it can increase your risk of AFib, even though I got ablated. So I asked OpenEvidence, should people with this history do it? Then I went to deep consult. I got 2 different answers. I got a custom answer for myself where it said, actually, no, stay under this dose, you'll be okay.
We're actively improving deep consult to actually turn into 2 separate models, which we created a single model the first time, which was a conscious decision, but now we can do it so much better, where one is a true deep consult that is about deep patient history, and another one is much more kind of like a deep research version, which is we were trying to solve 2 problems at once, which was non-ideal. But the 2 problems are, when we built OpenEvidence and trained the model, there was a specific form factor that caused limitations. And that form factor is 5-second answers, as quick, as succinct as possible, so a clinician can answer the question and go about their day, right? So try and make it 4 paragraphs. You know, we're not looking for pages and pages of information. Now, if a clinician asks, what is the treatment for stage 3 lung cancer? There's no 4-paragraph answer that helps you with that, right? The NCCN is 60 pages on how to treat stage 3 lung cancer. It's impossible to summarize 60 pages into 4 paragraphs, right? And so point of deep consult is to go 2 ways. One, we throw off those limitations. So it could take as long as you want to answer it. It's a reasoning model. If it needs to go back over and over again, it can take 8 minutes, 10 minutes. We'll send you the email when it's done. It also has no length restrictions. So if we decide that stage 3 lung cancer takes 6 pages to answer, we will give you 50 references in 6 pages, right? Like, take as long as it wants. The other issue was long context. The original model did not do a really good job if you like, I am going to give you 4 pages of medical records. You know, say you're one of the systems we have HIPAA, you know, a BAA with, and you want to paste in the entire medical record. The original model did not do a good job at that because it was trying to find, okay, I need to find 12 references for all the stuff going on and all the things. So the deep consult was a way to parse through that in an agentic way. Those are actually very separate problems that we answered with deep consult, and very soon we're going to have separate models. One is truly for a deep dive into patient record to find all the breadcrumbs that you may need or may miss, and a second one that is really more for research, which is how do I comprehensively identify everything that's relevant for this specific question, no matter how long it takes, and that, you know, more for research, for deep dives into questions.
When you get more into the agentic field of deep consults, and it does feel like deep research, it asks you those questions and comes back, do you increase the risk of there being some hallucination? Now it's taking the data, but it's also thinking through it in more complex responses?
So there are a lot of different failure modes in language models, right? And maybe I should cover them, right? Because it's really important to think about and talk about. The risk of hallucination doesn't go up with deep consult. What there is a risk for is inaccurate wayfinding. So for example, what we try to do with deep consult is ask the right questions. But what if we ask the wrong questions, right? What if we don't ask the questions that help us get to the right answer, and instead we ask distracting questions? You answer them, we find the right answer, but it's the right answer to the wrong question, so to speak, right? And so doing that really well actually involves making sure your first step of search medical literature is really good, because those questions are based on the papers that we found and how to parse through those papers to find a more targeted answer. Hallucinations, I don't think, go up, but making sure that the wayfinding, that is guiding the person to give us the right information, to give them the right answer, does lead to more forks in the tree, and like making sure they go down the right path is a challenge. Maybe since we're talking about failure modes, and you've mentioned hallucination a couple times, hallucination really is not a problem for open evidence because of how you described it's based on it. So what is the problem is we have to make sure that those references are the right references. And so we have to spend, every day we have dozens of engineers where all we're thinking about is how do we make sure that we have the right references we start with. Because if we don't have the right references, it's not a hallucination, but it's writing on the wrong material, right? Yeah. Failure modes, always important to talk about in AI. Each system has its own risks. And so while hallucination, I think, is something that is fairly well solved, just like with chat, if it has the wrong references, it's going to be writing about the wrong things. We have to spend so much effort making sure that we have the right references, like we're pulling from them, and that is two pipes. We got to make sure the data is good, that we are getting the right references from journals, from societies, from the FDA, and then that we are creating ML algorithms to find the right references when someone asks a question.
This is why, as clinicians, we love it so much. You really can't trust it.
Yeah, exactly.
I mean, of course, we've all had LLMs make up articles,
Yeah.
not in open evidence, but in others.
Yeah.
That makes a big difference.
Yeah.
In preparation for this interview, as I told you before, our residents, love it. Our house staff, all our faculty, but nothing speaks to the future of open evidence and all this than our future. I polled them. I asked them, what questions would you like Travis to hear from? Here's the most common theme. I was surprised. 6 years from now, all of a sudden the internet goes out.
Right. So what do I do? Right.
But are we deskilling? Are we taking the scalpel away from the surgeon and having him do surgery? Is that a concern? How do we avoid that?
I talked about it a bit during the lecture. There's a part of me as an oncologist, right, that if I lost access to a lot of the EHR, it would be very difficult for me to practice. And so we are continuing to dependent. Like, I don't know how much I trust my skills as a wilderness medicine oncologist, right? So we are continually dependent on the skills that we trained with, or the tools that we trained with, and the skills. I think with active utilization of these tools, just like with active utilization of PubMed or others, where you're not just using it to get the answer, but you're spending 15 seconds to understand why it's that answer and trying to just ingest it a little bit. When the lights go out, you're actually going to have a better understanding of the primary literature and the guidelines than you would have had if the reverse scenario, which is a lot of times you're like, oh, I do that because that's how my attending does it. And I think that a lot of medicine has been done this way, where we do what we were taught to do, and there's a lot of like incestuous learning because it takes so much effort to go figure out why we're doing what we're doing. So I think if we lower the activation barrier to actually learning why we're doing what we're doing, as long as we are spending that time, especially as trainees, doing the 10 seconds to be like, okay, I understand it, this is where it's coming from. When the lights go out, you're actually going to have a better knowledge about what to do than you would have had otherwise. But that inoculation and active utilization is incredibly important to that.
And on the flip side, I learned from your talk today, you're playing a huge role than I realized in educating. You have the data to see where, as a hospitalist, what I actually need. How many times have I taken a test for my maintenance? And I say to myself, why do I need to know this? You actually could guide.
We were talking to board exams constantly. I had talked to the American Board of Pediatrics yesterday about what is the responsible way to do this. It's really interesting to me talking to them is like, if we have all this data, let's forget the individual user. If we have all this data on what's actually relevant to practice at different stages of training, and you compare that to their core competencies that they train on, how do we actually pair that to create longitudinal assessment or a maintenance of certification that actually helps people fill deficiencies? We have very strict rules around privacy, so we would never give raw query data for any individual user. It is interesting to think about if you're a PCP who's working in Oklahoma and all of a sudden you are having to do much more OB than you ever have before. At the end of the year, we look in what you've done and you're doing a lot of OB and you're not doing a lot of maybe pediatrics, I don't know, something else, right? If you're a board exam, Do you want to spend time teaching about OB to that person who you may now have more knowledge about what they actually need to practice? Or do you want to spend more time teaching pediatrics because they aren't getting it during their practice? I think that's interesting. I don't know if there's a right answer there necessarily, but it's interesting that we can now think about the fingerprint that we could potentially help to use and guide. How do we make these longitudinal knowledge assessments useful to helping me be better at my job and not just a waste of time that I have to click through to get on with my day?
This is a general question as someone who is in this space so much. I don't know if you've heard of this song called Papa Ute. It's a famous French song, but it's very famous everywhere. It's in French normally.
Yeah.
I love the song. There was an English version that came out just this year, and it went viral. And I love the song. I go back to listen to it. It's not available for streaming. I research it. The song was made by AI. Somebody had recreated the song, made a dance for a faster version, put it in English, and I had no idea.
Wow.
I even looked at the video when I was searching for it, and I saw this woman singing, and I was like, oh, this is her. And I didn't realize she was AI.
Wow.
That was an aha moment for me, because for the longest time I didn't think, at least for certain aspects, AI would infiltrate.
Yeah.
And it makes me think about my interest in humanism, medicine, physical exam, the bedside. And my understanding had been, teaching bedside medicine, that if anything, it'll give us more time at the bedside to be humans in connection.
Yeah.
But I'm also wondering, will AI actually take that role too? If I have a buddy who answers all questions for me anytime and is smarter than anybody else and can help reduce my anxiety if I'm worried about something, isn't AI maybe going to even fill the gap of humanism?
Maybe. I don't feel that way for a couple of reasons. My experience with patients and what they have access to and what they don't have access to, and what they choose to make decisions based on. I see it as a foreshadowing to what they will want to help make their decisions in the future. A lot of patients come in and they have all these resources to get information from. And they know the right resources, right? They know the ones that'll probably give the right answer. But the one that really helps them decide the right answer is the uncle who went through it. Like a family member or a friend that they trust. A lot of times that can be the bane of a physician, right? And it's not the point of whether the answer is right or not. It's the point of where the source is coming from and why they're choosing that source versus the other sources that may even be more accurate, right? And I think they're choosing it because they recognize there's a true part of empathy there, right? There's a shared experience that person experienced something and I can see myself in that experience in my trajectory, right? And so I think that there will always be that same element for human physicians, where it's a patient can get all the information they want from an AI, but what they want to know is they want to know what a physician who's been there, who understands it, who's seen 20 other patients just like them, what they would do in their situation. And it is very hard to believe AI model when you ask it, what would you do if it was your mother? Which is, what patients have often been at. That's a lot of times what they do. It is very hard to believe that an AI really knows what they're saying when they say, this is what I would do if it was my mother, right? So I think there is that human element. Beyond that, clinicians have a much harder job than they often give themselves credit for. And that's both true in a humanism perspective, but it's also true in the decision-making perspective. And a lot of the decisions that physicians end up making are not driven by evidence for good reason, right? They're driven by the patient in front of them and the patient in the room. And it will be very hard for a ML model to find the data to train on to make those kind of decisions. That is one person's perspective, and just because I work at OpenEvidence, which has 150 million questions asked by physicians, I'm not sure I'm in a better position to talk about that than any given physician, but that's my perspective.
It means a lot, and your perspective is very valuable. As we talked about, our house staff and all house staff love OpenEvidence. What advice would you give a medical student, a resident, early faculty? By the way, I think I'll listen to this advice you're about to give for what they should do with their career. How should they make sure that they stay relevant and have the skills for the next 10 plus years of their career?
Well, maybe let's talk about clinicians specifically, how to be a clinician. I think there's been a lot of our identity in the last 50 plus years of being a clinician around this really an inhuman task that we've been asked to do, which is like You are going to, when you enter medical school, your job is to be Encyclopedia Britannica for everything related to medicine. You have to know it all, and then in addition to knowing it all, you got to know it even more than that for whatever specialty and then whatever subspecialty. And if you think about the pace of knowledge generation, that is an inhuman task, right? But that is, we have that in our identity. It's kind of baked into our identity, is that's what it means to be a good doctor, is to know everything. There's the other part of our identity, which is the reasoning. I would say, which is a much more human task, which is the reasoning in humanism. How do I take that encyclopedia knowledge and apply it to the patient in front of me? And I think that's a much more human task. And I'm actually excited in the next 5 years that I'm hoping that there'll be a lot less of the first one when it comes to training, and recognizing I don't have to be Encyclopedia Britannica. What I do have to be is really good at reasoning, and that does involve fundamentally an understanding of the system I'm working in, and I mean that in all the ways, right? The basic pathophysiology, the hospital system, patient interactions, all those things, and how to take the knowledge that I can get and apply that in the system that I'm working in. And so I'm hoping in the next 5 years there will be a lot more focus both in training and in practice in that second part, which I think humans are much better at than being Encyclopedia Britannicas. From a career perspective as a clinician, I think it's really hard to determine what that trajectory will look like. My hope is that there will be a lot less of the mundane operational tasks that we've been burdened with for the last 20 years. And that includes some of the easier things in medicine, and we'll get to spend more time on the harder things in medicine. My concern is it'll just mean that we'll see more patients. And I think it's on us to try and fight that to some degree, right? Absolutely. If we're saving any time on operational tasks, we need to at least reserve some of that back for what medicine is supposed to be about. Because otherwise, I think we'll actually deliver worse care to more people instead of better care to more people.
It's a perfect segue. We have among us, I understand, 4 children, 2 children each, both young. I have mine is slightly older. My oldest child, 8 years old. If my daughter were to ask you, or any of our children as they get older ask you, what should I be when I grow up? Or if they were to just say, I want to be a doctor, what advice would you give them?
Those are 2 different questions. I was raised by 2 great parents who always believed that you should grow up to do whatever you love doing, because if you love doing it, you never have to work a day in your life. I believe that. I've done that, and it's been great for me. So if they were to ask me, what should I do? I'd be like, do whatever you love. And that can change. Obviously, as a 4-year-old, that might be different than an 8-year-old, 12-year-old. You have responsibility as parents to make sure they can achieve whatever that is. Most recently, my daughter wanted to be a doctor for marine animals. That's awesome. I can't wait for her to be a doctor for marine animals. We took her to the marine mammal exhibit in Marin recently. So that's answered part 1. To part 2, if you really love understanding the human body, understanding what can go wrong, and helping other people understand that and walk through that journey, then you should be a doctor. And I think there will always be a place for that in human society. That might not be helpful if you're, what does that mean? Where will we be? Is that going to be, a minimum wage position versus where it is now? I have no idea on any of that, but I think if you feel fulfilled doing that, then I see no reason why you shouldn't aim for that.
You mentioned a concern about seeing more patients. Is there anything else that concerns you with all the changes that have or are coming?
Deskilling is something that's of concern to me. I do think that not just seeing more patients, but being pushed more and more to a technocrat, technical, just a technician, more or less. That was already happening. And I think that if that push, for volume and efficiency continues, and we just see as AI as a way of improving efficiencies as opposed to improving quality, there's going to be a loss of a lot of what makes medicine fun, but also we're going to lose a lot of the quality of care when it comes to people that fall outside the mean. I'm concerned about this focus on efficiency. You start to lose maybe taking care of the people that don't fall right within the one standard deviation of the mean, and those gaps and the people that live in that space by people, just the conditions, the rare diseases, people that don't respond the same to medication may be left out because everyone's so focused on just whatever is within the line of evidence-based medicine and efficiency. So I think those are my two biggest concerns.
It sounds like you're working to make sure all the patients are captured in one way or another.
I think about it constantly, right? It is a very tough problem, especially in the AI space. For me, what I like to think about is I want to raise the floor, right? I want to make sure everyone's getting standard of care. And then I want to make sure that every physician has the tools they need to take care of those edge cases. Because again, as I've kind of said over and over again, I really feel like that's where the human really comes in. There are a lot of things that we're excited about doing and supporting for is like, well, let's find the expert. Let's figure out what the expert would say about this edge case. Or even better, if you are a primary care doctor who's seen IgG4 disease, it's the first time you've ever seen it, let's make sure you have all the information you need for the first step, and let's tell you where the expert that lives closest to you is so that we can connect you to the right place, because we have such a network of doctors now. Facilitating those edge case identification and treatment.
Last question. You talked about so many things you're excited about, and your face lights up. It's wonderful to see. What are you most excited about for the future of medicine?
So I'm excited in my world in the two things. I think we've touched on both of them. One is I really feel the impact is proactive monitoring, and I'm very excited about that. A human can't be there every day for every single patient. A lot of times a patient will come or leave a doctor frustrated, thinking, I knew more about what was going on than they did. And the flip side is the doctor only had 3 minutes before the visit and 12 minutes after the visit. And that's very tough. And I'm very excited about the idea of you have an AI system who's thinking about that patient 24/7, so that during the 3 minutes the doctor has, they have the summary of exactly what the flags that have come up and where to look to verify that information. So those 12 minutes with the patient feels, wow, I can't believe the doctor understood all that and already had a plan set up. So that kind of like proactive step. I'm very excited about that. And then the other thing I'm very excited about is working with the experts who have been practicing for so many years to fill those gaps in knowledge that we're identifying in a way that 500,000 doctors, the minute we fill it, have access to it. We both trained in very privileged places. And one of the things I love to talk about and reflect on that is I am not an expert clinician. Even when I was 80% time in the lab, right? But I trained at a place where if I had a clinical question, the expert was in my phone, right? I can ask them on my phone. And what a privilege that is for my patients to be lucky enough, not that it's me, but I just happen to know the guy. And how do we expand that and disseminate that kind of knowledge and access to all the doctors in America so all of their patients have that same kind of privilege in a way that is responsible for the experts' time? That's where we're like looking at where are these gaps in knowledge that we can then go to experts and identify and find ways to create knowledge, whether that's working with a society, identifying the gaps and have them create panels to identify it, or even finding the expert in an ultra rare disease and help them understand this question that a lot of people are asking. So that's the other excitement, is creating new knowledge.
My favorite line was always, I may not know the answer, but I know someone who does.
Exactly.
Thanks to you, now everybody can say, I may not know the answer, but I know OpenEvidence does.
That's true.
Travis, thank you so much for your time today.
Thank you.
That was awesome.
Thanks so much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.